have the second panel of discussion, which we will be talking about role of analytics in healthcare system. And we would be discussing more on analytics making inroads into healthcare system, challenges in data availability, awareness, importance and readiness in integrating technology in government departments. So this is the second panel discussion we would be having now. And to moderate this session, I would like to call upon Dr. Sudha Chandrasekhar, Public Health Specialist and Health Economist. She will be moderating the session for us. I would like to call upon the other panelists who will be joining us for this discussion. Dr. Ratan Kelkar, IAS, Secretary, Medical Education and Executive Director, State Health Authority, Government of Kerala. Request you to please come onto the dais, sir. Further, I would like to call upon, joining him would be Dr. Bijoy E., Joint Director, Operations, State Health Agency. I would like to call upon our key speaker, Dr. Karthik Adappa, IAS, Special Secretary, Public Health and Family Welfare Department, Punjab. Further, I would like to call our other key speaker for the discussion, Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir. The other panelists for the discussion, can I call upon Professor Dr. Gangadhar, MD, DM, OSD to CM of Health, Technical Advisor, Department of Health, Medical and Family Welfare, Government of Telangana. Moving ahead, can I call upon Ms. Indrani Lashkar, Joint Secretary, Health and Welfare, Department, Government of Assam. Joining us, other two panelists would be Dr. Subodh, Professor and Director, Center for Healthcare Management, Director, ASCI PGDM, Hospital Management, Hyderabad. And the final panelist joining us for this discussion would be Mr. Prashant Rai, Senior Business Solution Manager, SAS India. We have Dr. Ratan Kelkar, who has joined us virtually, so he will be there on the screen. The moderator can pay attention.
A very good afternoon to everyone assembled here and to all the distinguished panelists on the dais. So it's really an honor to moderate this technical session, and I'm sure it will be really interesting, but we will have this as a very crisp and a short panel, because I do understand that we have an inauguration plan and also it's a pre-lunch session. So we will make sure that all the panelists are quite crisp in their comments, and also we will have some time for questions from the audience, because that's also very important, because we have presenting multiple states and different fields. So looking at data analytics is something that every policymaker would always want to know, right? What is data telling me? And how do I use it? And how can we make it more applicable to our decisions? I think that's where this whole panel will link to, is how do we use data for better informed decisions? How can technology help? And what is the future that holds, and what are the challenges? I think that's what we would cover in this panel, with the experiences from the states, at the center, at the academia, and at the policy level. So we have representations from the political side also. So I would also look at that angle as to how data can help their decisions. To start with, we have Dr. Ratan Kelkar, who is the Secretary IT and also the Executive Director of the State Health Agency, Kerala. So welcome to the panel, sir. And I know that you have worked in the health department for quite a long time, and now heading the IT department also. So how can we enhance better use of data through IT integration, especially when Kerala has been declared as a fully e-governed state? Your comments, sir, on that.
It is indeed a wonderful event being organized. Unfortunately, I couldn't be there. So using the formalities of IT, I could at least get an opportunity to join this online and in the virtual mode. And that is indeed one of the benefits of IT. And Kerala, as you have rightly pointed out, has declared Kerala state as the completely e-governed state. And as part of governance mechanisms, one, what we are looking at doing is bringing everybody onto the IT platform, all service providers in all the departments, all the stakeholders, so that we create a mechanism of interaction between various silos that we generally see in the government. Now, coming to the use of data, data will remain just a piece of mathematical mathematical data, or just an information if you do not act upon it. So what makes information very relevant is the most important aspect which we have tried to address. We have tried to use the data which is coming from the field, mainly for our monitoring and evaluation purposes of various health schemes, as the vertical in the health department. Similarly, monitoring and evaluation is the core which we are insisting from the IT department to all the departments, so that they take a stock where they are heading. Generally, in a program, in this particular context, the health programs or the PMJ and other health schemes which are being operated either by NHA or by NHM. So what we generally see is we are in the process of implementing multiple programs, and we are all in a race where we are trying to achieve deadlines and goals, whereas we somehow down the line we miss looking at the data which is giving us a reflection from the field, and taking any corrective actions as we go along. So this is one which has led to the schemes not being implemented in the right earnest, or we are not getting the true value for our inputs. So what we have tried to do is create a mechanism of continuous monitoring and evaluation, looking at the data and analyzing the data, so that we can take course correction and also important policy decisions for the health programs to be implemented in a better way, and also for not only health vertical, but also all the departments, so that they have a look at their schemes. So the most important point of analyzing a data is to give a feedback to the implementers, to the policy makers, so that they can take course correction and implement the program in a much better way by appropriate policy level interventions. So that is what we have put in place. And one of the success stories is the state and agency, which has very meticulously followed upon the data which is coming from the NHA IT system, the insights. We have also a state where we look at the data and take corrective measures. So this way we have been able to improve the implementation of PMJ, and we have also been able to implement and also uh, coordinate with other departments who are handling health schemes and take over these schemes. There are good success stories which my colleague Dr. Vijay will probably speak about today in the forum. So we've been able to integrate multiple health schemes also with PMJ, so that we bring everybody under one common umbrella. And this has been possible because we have seen benefits of this kind of a convergence by looking at data and using the feedback which comes from this analysis.
Thank you, sir. And continuing the Kerala experience, I would like to request Joint Director Dr. Bijoy. How did you actually work with the data to convince the government that there are multiple schemes that your state was implementing, and ensure that we have to converge these in the state of Kerala?
Thank you, madam. And thank you for the IndiGlobal team for inviting us for this prestigious program. And regarding the question, when SHA was constituted, the primary objective was to integrate all the other health financial schemes to single umbrella. So what we did is, as a first point, we initiated with the Karunya Benevolent scheme, which was implemented in Kerala, run by the lottery department, and the revenue was generated from selling one lottery. So it was implemented separately. It was totally not IT related system was managed there. So the first thing we did is we integrated the KBO system, Karunya Benevolent Scheme, into the PMJY IT platform. And we analyzed the data after 1 year. So after observing the data, we could identify that we can save a lot of money after integration the schemes to the similar platform like ABPMJY CASP. So after analyzing this, we could able to convince the government that we could save money because that if we able to integrate all the health-related financial schemes to a single umbrella. So after that only we could able to, we got the direction for integrating another scheme, which was Arogya Kiranam scheme, which was a completely state-sponsored scheme. So last year onwards, we started implementing the Arogya Kiranam scheme. This year, we privileged to have integrate a lot more schemes, which was run by the other departments like Kerala Social Security Mission, like Talolam, Cancer Suraksha, and Sudhidarangam scheme, which was completely sponsored by the government-funded scheme. So this year onwards, we are integrating that scheme also to our ecosystem. And for other schemes also, which was run by other departments like labor departments, and also we are planning to integrate with this. This thing which we able to do, that we could able to convince the government after analyzing our data, the data which was available with us in the IT system. That is one success story that we could able to convince the government for integrating all these schemes. Thank you.
So definitely, this is one example of how can you improve the efficiency of your scheme implementation by using the data that you already have, and also look at how that can have cost-saving implications also, because it gets run by a single administration and a lot of parallel complementary benefits would also arise. So that's an example of how you use data within the government and make the decisions and convince stakeholders to agree for, the changes or the reforms that you propose. We have with us from Punjab's Special Secretary Karthik sir. Sir, data analytics is a core component of public health management. Can you share an instance where this has shaped public health programs or the design of some reforms in Punjab?
Thank you for a great question. I also recognize that the audience typically are all medical students. So I want to kind of start a small anecdote as a medical student, because I'm a medical doctor by training. I did my MD from All Indian Institute of Medical Sciences in internal medicine. And then I came to work in the IAS in Uttarakhand, then worked in Punjab, and essentially largely in public health work. And then went on to do a master's in public health from Hopkins, and then did a PhD in health informatics from University of North Carolina. Now, the reason why I'm sharing this journey is when I went to medical school, we hardly had any technology. So leave apart data analytics or advanced AI and machine learning. So what I want to impress upon the young medical students sitting here is no longer should medical students just think about just clinical medicine and practicing medicine. It's so much more important to have engineering skills along with medical skills. And that is by far one of the reasons why in the US, there's a school in Chicago, in the Illinois state, which actually has medical training and engineering training as a part of the medical school curriculum. So that is, I think, the need of the hour. Now, coming specifically to this question, I will give you some examples. Now, I do research in top-end medical schools at Yale and Stanford at UNC. Those are examples which, of course, are at cutting edge globally. But what I want to give you examples are from India, and specifically from Punjab. So what we're essentially trying to do is, you've had an interesting talk from SAS, where the speaker was trying to highlight that in terms of computer image analysis, there's a lot of advanced research that has already happened. So for example, today, if a primary healthcare physician gets a dermatological patch and he doesn't understand what could be the potential diagnosis, now with AI and machine learning, you can actually get a variety of differential diagnoses that this tool, AI machine learning tool, can help you in. Similarly, when you have the fundus image for a diabetic retinopathy, it's possible that you don't have an ophthalmologist in the primary healthcare, but this AI machine learning assistant can help you make some differential diagnosis. Similarly, even for cataract. Now, so what we're essentially trying to do is in Punjab, in the primary healthcare, what we have are called the Aam Aadmi clinics. Now, in these clinics, for a typical primary care physician, when they get extremely complex cases where they cannot diagnose. So we have these small AI assistants. These are all at a proof of concept stage. I want to be very careful before I promise the moon. These are all fairly early. They're all being tested in the clinical environment, but also being used to help the primary healthcare physician. Now, essentially, when we talk about AI, machine learning, or even data analytics, all of us talk about their benefits. But as somebody who develops them, I also want to tell you that AI and machine learning, like a drug, there are safety concerns that are associated with AI and machine learning. So what we are trying to do is, before we actually truly deploy data analytics or machine learning tools onto the population level, we want to ensure that there is science involved in the machine learning and the algorithmic development itself. So just like how when you take a drug, it goes through 5 different phases, even AI machine learning tools that are getting deployed into the real world are going through this phase development, right from the proof of concept stage, the development stage, the algorithmic optimization stage, and finally to the real world. So a lot of our applications that we are using in Punjab, whether it is for cataract screening, where for diabetic retinopathy, for dermatologic screening, and a variety of these applications, yes, we are helping them. We are helping the primary healthcare practitioner to send and refer cases to secondary and tertiary properly. We are using AI largely as an assistant. My understanding is even AI and machine learning, even as it develops in the next 20 years, is only largely going to be an assistant, and you will still need human in the loop. It is not that the machines will come and replace physicians. They're largely to help supplement and complement physicians. So the reason why a next generation physician needs to understand AI and ML is largely to understand its strengths, but also understand the risks and the safety concerns associated with AI and machine learning. So I also want to take this opportunity to highlight some of these concerns, and I know there are other speakers as well. So I'll stop it here, but I would be very interested to take questions from the audience at a later stage. Thank you.
So we do have a second round of question on the challenges, so we will come back to you on that. But definitely it gives an idea that the government is not behind in technology, and it's not technology being applied only in the higher levels of care, but also to the primary healthcare level, which we were discussing in the previous panel, that primary healthcare is also very important. So happy to see the progress in that space. Gangadhar sir, specifically access to data and integration of multiple health information systems has to be ensured to make meaningful inferences, not only to the decision-making body, which is the technical, but also to the political leadership. What steps have been taken by Government of Telangana towards this, and how do you see it moving ahead to help the political leadership also to make such decisions?
Thank you, esteemed panelists. So basically, I'm also a doctor, as sir was telling. When I was in MBBS, only bedside teaching was there, where our data is coming from only bedside. When I moved to Nizam Institute of Medical Sciences, then I went to Harvard for research. Then there is a called as a bench to bedside. But later on, when I came back, it came to bench to bedside to, again, bureaucracy. When you are making a policy, there are 3 levels of communication. One is scientific communication, second is a political communication, third is a public communication. Wherever it is there, now I am working as a OSD to the Chief Minister of Telangana and also technical advisor, where my job is to make the scientific communication palatable to the public and also to the political people, where this data emerging from scientific basis need to be communicated in a way the political system will understand and the public also understand. Because in a democratic country, a lot of solutions lie with the political solutions only. I'll give an example of, I'm a nephrologist basically. So what is data means, how to convince the political system to make a universal health coverage in at least in kidney angle. So let us say I was actually returned from Harvard, where in 2014 when Telangana was formed, I was inducted into the ministry as an advisor to the Honorable Minister at that time. So basically the kidney care at that time was not universal. Dialysis was not given full to all the population. Then we generated the data. How many patients are there in Telangana state who requires dialysis? Then where we should keep the dialysis centers? How to manage them? then how can we fund them? So these sort of data was generated, and the political people were briefed. The minister was briefed, Honorable CM was briefed, and public also, like MLAs were briefed. Then it became a political agenda now. Now, no nephrologists are asking for a dialysis center. It is the public who are demanding for dialysis center. It is a politician who is demanding for dialysis center is their own area. So that's how the issue was brought out in a scientific manner to them. Now issue is settled now. Now in Telangana state, we are spending 100 crores only on dialysis centers, and 119 centers are there in across Telangana. Each constituency of Telangana state now is having a dialysis center where public are not moving not more than 30 kilometers to access dialysis care. That's how the issue of dialysis or kidney care was brought out in an opt manner to the public and also political system, where now issue is settled. So this how a administrator should be briefed in a proper manner. The scientific communication should be made to the political people, political communication should be proper, then public communication also should be proper to evolve any solution. It's our democratic country. So whenever you want any solution to healthcare is one of the issue. That issue need to be properly briefed to the political and also public system, where the issue should be maybe public agenda, then political agenda, then the problem will get solved. So the only one example I have given, that's how the Telangana is moving. Like initially Niti Aayog ranking was 11 in Telangana state. That was also brief. Now we are in third level. Our IMR at the time of Telangana formation 39, he brought down to 21. Then the maternal mortality was 93, it brought down to 43. So this how these numbers matter. These numbers, what are the data analytics matters. And they need to be properly communicated to the administrations, like bureaucracy should be briefed, the political system should be briefed, and public also should be briefed in a proper manner. Then they become an agenda. That agenda issue should be there in agenda, that one agenda is there, then solution will come. Like maternal mortality was agenda item. 93 per lakh population was our MMR. Now full administration was geared up, political system was geared up, public is geared up. Now it become to 43 by establishing more MCS centers, by establishing high-end ICUs where agenda is there. Then after that MMR, where more SNCs were there, high-risk deliveries are identified. That sort of a solution came up. Now we are in rank number 3 in the country. So that's how the political system was briefed by whatever we are, a lot of doctors are there. Apart from doing individual patient care, it's our responsibility that we are social doctors. We are not only a medical doctors, but our responsibility lies with taking care of society also. Apart from taking care of individual patient, we should also take care of the entire society. So taking care of society, we need to brief the administration properly, the bureaucracy properly, and also the political people and public also to properly to evolve any solution. That's my experience in last 10 years I'm with the government, so this is my experience, ma'am.
Thank you, sir, for emphasizing that data can be a strong lever for political advocacy. So definitely issues need to be taken up, and how do you shape it? Data analysis and insights can definitely help with that. So moving to the kind of reform that the whole country is going ahead with, the Ayushman Bharat Digital Mission is a game changer. And we have Dr. Shakat Khan from Jammu and Kashmir, who is Digital Mission Director. So J&K is embracing the digitization in a big way. What are the steps that are taken in this direction by J&K and other initiatives which you feel will complement this digital mission?
I'll take this opportunity to first thank the organizers of this very wonderful event today. Where we have such dignified people with great amount of knowledge, and this knowledge is getting interchanged between us and the people of Hyderabad and Telangana. I have great love for this city, especially Hyderabad. I have been here, I have done my master's in health administration here from Osmania University. And believe me, I call Hyderabad the heart of India, you know. No city in India is so beautiful and with beautiful people and with beautiful, you know, ideas, emotions, everything mixed together. Ayushman Bharat Digital Mission is a flagship scheme of the Government of India, which started in 2021 Honorable Prime Minister inaugurated the scheme. And I call it the second milestone in healthcare transformation. The first milestone was the Ayushman Bharat PMJY, the health insurance scheme, which we all know has transformed the lives of the rural India, the lives of the poor people for whom things were not affordable. Health finances would cripple families, in India. It was the biggest burden on families when it came to, spending on healthcare. So, having said that, J&K has a universal health care scheme which envisages a cover of 5 lakhs, irrespective of the size of the family, irrespective of the size and the pre-existing diseases. So, we have been able to rope in 80 lakh of our population into the scheme, and our monthly expenditure on the scheme is around 4 crores. And overall, we are, implementing the scheme in a huge letter and spirit way, which is proving a very big boon to our entire governance system. Ayushman Bharat Digital Mission started a little later in 2022 July, and as you all know, the Ayushman Bharat Digital Mission is going to transform healthcare entirely 360 degrees. As Dr. Karthik said, it's not going to replace doctors. There's a misnomer that it will replace the healthcare professionals. It will not. It is going to augment, it's going to, make healthcare much easy to deliver and for the citizens much easy to, receive. It is just a way of creating ease of business. The papers, the transactions, the records will go into repository, into a central repository in your healthcare Abha ID. Abha is a Ayushman Bharat health account. Some of the students here may not be knowing. Every one of us will have to have a Ayushman Bharat health account. And that health account will contain your entire repository of your health records right from your birth till the last breath. And that will facilitate, number one, your entire treatment with your records. It will facilitate ease, you don't need to carry all those records. Then the child from the birth will know when his vaccinations have taken place, automatic on your cell phone. You will put your records into maybe a DigiLocker, or it'll be a cloud-based information. It'll be a secure consent-based information management system on your, cell phone, meaning that you will be the manager of your, information. You will share it with a health institution or a doctor with consent, because, the questions of security of this data comes into, question. But having said that, since we are talking about data, what has data done to our lives? This big data we are generating in our country is of huge value to us. Please understand, our institutional delivery in J&K is 97%. Who could imagine J&K like state, which has a very huge, vast area, hilly area, difficult to reach area, can have 97% institutional delivery. Our vaccination, process is already touching 100%. And that is because it is all digitized. The COVID app has, been the win-win situation for our great country. And it's a global success story. So many people, such a huge population, got vaccinated, registered, and re-registered, and re-vaccinated and all. So my point is that data is going to be the future gold, and we'll have to preserve it well. There are, of course, questions of security of data. There are questions of keeping it in safe hands, and that's what the government is ensuring at the highest level, that this data should not be breached, this data should not go to some adversary, it should not go haywire. And this data is actually a huge resource to build this country into a great country, which already it is on the path of being a great country, globally. So my point here is that we had highlighted some issues. We said, who is the basic healthcare provider? The basic healthcare provider is an ASHA worker, an FMPHW, a community health worker. You know, we have gone so far deep into providing healthcare. It is not the doctor now. The doctor maybe comes in the last. You have to understand how a prenatal, checkup for a woman till the entire 9 months. There's no doctor. There's an ASHA worker who is taking her, all the time, going to her house, taking all the notes and putting them, overutilized ASHA worker, I call her. She is hugely burdened. Whenever we have a function, we call ASHA workers, please come over. And they turn in hundreds. They have to walk miles. We overburden them sometimes. But trust me, our peripheral health system is strengthening like anything. J&K, for example, we had 500 medical seats. Now we have around 2,000. We have 9 medical colleges. We have 2 AIMS coming up. The Government of India, Prime Minister has been kind to give us 2 AIMS. We have n number of trauma centers coming. We have 2 cancer institutes coming, one in Jammu and one in Srinagar. We have also, DNB courses. DNB courses just started 2 years back. And we have 260 DNB seats. Now a person from Kerala, we have students from Kerala coming to Kupwara district. And that is integration. That is the beauty of the entire integration of this country. We see that as part of integration. When somebody from Kerala, from Chennai, a student is sitting in Kupwara and Bandipur and doing DNB, Bandipur, a district which was never considered, in Pulwama. Pulwama, you must have heard for all the wrong reasons. But today, Pulwama, there are startups. There are, young minds opening cafeterias, doing pottery. We have one of the best minds. Recently, one of our KS toppers came from Pulwama. We have few IS boys coming from Pulwama. So my entire, argument goes into saying that digital revolution is, anything. Our chief secretary yesterday, day before, we had a conclave, said anything which is not digital is suboptimal. It is not optimal. So we need to, put digitization in everything in our sphere. And I tell people during my interactions with, the healthcare workers and others, that please embrace digitization as fast as possible, because it will embrace you anyway. Today, if you have to buy a ticket, you have to use your smartphone. You have to, otherwise you will end up paying more with the travel agent and all. Or, book a train ticket, go for information, go into Google, find out things. So I feel that this boom of digital boom in a country is going to conquer the world, trust me. It is going to be the key to our success globally. And we as a country, as one of the earlier panels said, we are very hardworking people. We are workaholics. Indians are the best minds and the best working category. That's why we are sought all over the globe. So we can do it. I am sure if we run this the way it's going, I see huge success for this country in the coming days and years, and wish all of you good luck. Thank you.
Thank you, sir. Yes, as the country embraces digitization, I think the use of that information is where it matters. So being a joint director at your state health department, it is very important that your officers and your nodal officers at the district, at the program level, need to make sure that all the digitized data makes sense to them and how they can actually alter the course of the program. So any thoughts and experiences on that, ma'am?
Good afternoon. At the outset, I would like to thank the organizers for such a beautiful summit. And as for me, I would like to say that I'm not a doctor, I'm an out-and-out bureaucrat. So whatever I'll speak from the layman point of view and from my experience in the health department. And so far as Assam is concerned, we are not in a big way so far as data analytics is concerned, like in other states, but still we have taken up the Ayushman Bharat, and so far we have been able to generate the Aadhaar cards. And we have made significant progress because around 1.38 crores of Aadhaar cards has been generated. And then we also generated the health records. And then we have also taken up the wellness centers, which should be around 4,422. And then speaking of the data analytics, from my own experience in whatever small way that we had been trying, I could see like it's sometimes very difficult. First and foremost, the data is there, but then it is difficult because they are not standardized, they need to be filtered. Then this is happening mostly because I totally agree with Adapa sir that the doctors, they are very good in their own profession, but then again, they are not that technically aware, or maybe because they were so much immersed in their, in the medical field, knowing well that how difficult it is to become a doctor. But then somehow, like maybe because they are not that much trained in, when it comes to technical matters. So sometimes, and even if they are being given the task, they feel a bit, reluctant, like why I am doing it. Maybe in the course of time and giving the changes in the healthcare and the way that we are having, especially with the launch of the Ayushman Bharat, we will all pick up the threads and they will obviously pick it up. And I have seen signs that they are doing well also. And second, going back to the data generation and all, I think I listened carefully to Kerala experience, and this is something which we can learn from. And sometimes what happens is that, yes, we also need, so when it comes to awareness, government is aware of the importance of integrating technology with in government schemes and all, aligning the technology with the needs of the people. But then what is happening is that when it comes to the awareness, we still are learning and we still need to motivate, because sometimes what happens is that it is still like a kind of ad hoc kind of a planning that is going on. I mean, not exactly, but sometimes it happens. So that has to be worked upon. And as I said, yes, awareness need to be given, not only with only the doctors, but also as every one of us who are in the administration. Because sometimes what happens is that the person, like, okay, fine, he has to be given this work of portal and data management and all. I mean, someone who doesn't have the work, let him be dumped with that work. That is what was it, but now things are changing. That is also happening, and the poor chap, he doesn't know. And the awareness needs to be drilled into. And especially when it comes to Assam, I feel that we are also grappling with the logistical planning, and we are trying to strike up especially with the supply of medicines and drugs, which we are trying to streamline. And we are making some progress in it, and in the long run, maybe we will take rapid strides. As of now, we are still in the baby steps, and I'm also learning, our people are also learning. Thank you so very much.
Thank you. Yeah, definitely. You touched upon standardization of data and how that would help better usage, and also on the capacity constraints. So these are two, you moved already on to the next round, but definitely these are two key challenges on how do we use data. Now coming on to the other partners with the government, especially the academia and research institutes, they can actually contribute a lot in providing feedback to the governments on various programs, because they are the third eye, because they can distill this information much better and connect and give a lot of insights. How do you think this partnership can be further strengthened with the government?
Thank you, Dr. Sudha, and other esteemed panelists. So I will answer this in around 4 points. I think let's take to the COVID-19. I think that's when academia played a very big role, especially with the support of media. I think all the data, I think, which was in public domain, I think that was a time when we analyzed, a lot of predictive analytics happened at that time, looking at the forecasting, what happens, like for example, second wave to third wave, how much is going to be the shortage in oxygen, the ventilators, a lot of sensitivity analysis. What happens if your case detection ratio is going to be 10%, 15%? So a lot of analysis happened, I think not just in Hyderabad, but in other IITs, IIMs, a lot of analysis happened and very much picked up by the government, not just by the state governments, but by the government of India. So that's where I think a lot of analysis happened. A lot of data is there. I think immunization, everybody knew, a lot of data was there, but how much was the first dose, second dose, district level, program-wise. So a lot of sub-analysis was actually done by the academic institutes. The second part, I think many speakers actually talked about monitoring and evaluation. Monitoring is done excellently well by the departments, but when it comes to evaluation, that's where I think a lot of analytics can be used by the academic institute. So they bring, as Madam said, the third eye. You can actually bring in those extra angle, bringing all the stakeholders. A lot of analysis actually happens. One of the things we get to hear always at the state level, because we work at ASCII at a lot of states, and one of the things we get to hear is, "Hamare paas bahut data hai. We have a lot of data, but what do we do with this data?" Right? And second question we get is, okay, everything is there at the state level, but how do I know a district is different from another district? How do I deal with the tribal district? How do I do it a particular program? Can we do a sort of a sub-analysis? So that's where academic institutes come in very, very handy. And the last point I want to highlighting all these things, and there's a lot of talk about technology, digital health, is about the capacity building. Who are we actually giving the training to? As you rightly said, doctors, now to get them to learn Excel, statistics, they just straight away get. But actually, again, thanks to COVID, I think now telemedicine is being accepted. I know 10 years back, telemedicine was there, but now it has got a much more acceptance. I know doctors who are doing video consultations. We do have Practo apps showing you can go either online or a face-to-face. So a lot of opportunities have now come. But the point is, who are we training? Like for example, for any data analytics, it should ideally be the monitoring and evaluation person. So we need to identify those capacity building. I can give you a lot of examples where academic institutes are now supporting the government. And I always insist on hand-holding. It should not be academic institutes do it and live away. We need to hand-hold the government. For example, we are working with Arogyasri Healthcare Trust. We are sort of a knowledge partner, trying to hand-hold them, doing a little bit of analysis, helping to get to the next level. We have done the same thing with other states on health expenditure framework analysis, looking at where the funds are going, whether it's a primary care, tertiary care, or a secondary care. Where should we be putting the money in the next 5 years? But the focus is train your in-house team along with your accounts officers. It's not just, academia cannot just survive and publish papers, but work along with the government. Thank you.
Thank you. I think knowledge transfer to the government is very key, and I'm sure that is something when governments work with these academic institutions, they should add that as a clause. Whenever they are giving any kind of, contracts or, requests to participate and partner to make sure that there is a knowledge transfer and the local institutions can actually support the development of that capacity within the government. So, Dr. Prashant, there's a rapid progress of how data can be analyzed, presented to key officials. You had a whole session before our session. So I'll ask you a different question here. How do you co-develop solutions with the government? Because it is important that we can all come up with tools that have been worked wherever else it's been developed, but actually sitting next to the government and then co-developing it to the kind of, and tailoring it, needs a lot of effort than just developing a solutions as a standalone. So any thoughts on that and your experience on that?
Sure.
In short.
Sure. So I will begin with a very short story. So there is a Dutch statistician, John Rousseau-Fibo. He was a professor in one university. So on a fine day, he was taking lecture in the class, and somebody asked that I want to do some kind of analysis, and how much data do you think will be sufficient for this analysis? This is the question, very small question. How much data will be sufficient for this analysis? Tell me. He was a very famous statistician, he contributed a lot. And he said, no, I don't know. How do I know how much data will be sufficient? He resigned as a professor and he said that, why don't know? You are a professor, how don't know that how much data will be sufficient? Look at the situation, we all talk about data, day in and day out. as a data scientist from the data background, I talk about data day in and day out. And people ask, how much data will be sufficient for this analysis? Why don't know? Tell me. So he resigned from the professorship, and he spent his entire life figuring out the answer to this question. He died. He never came to know that how much data is sufficient for this analysis. Okay. Subsequently, probably 40 years after his death, somebody came out with the term of hypothesis testing. Hypothesis testing, forget everything. Statistics and machine learning is handicapped if you do not ride it on the shoulder of an expert who is domain expert. I have got huge amount of data. I don't have any hypothesis. What I will simply say, I have created one code which produces regression. Now go to hell with this. You have to have some kind of statistics is about translating your narration into the mathematical equation which can produce tangible outcome. That is about the statistics. It is not that on a fine day I have got great set of data, I will just bang my head against it, will produce whatever, garbage in, garbage out, will slap those results on your mouth, do whatever you want to do with this. I don't care. So, translating your problem, that is the foremost thing which you want to do. That is the narration, which will come from the expert like you in healthcare. The second part will be some kind of statistician who will translate this narration into hypothesis. And these hypotheses will be tested against the data. And this could be acceptance of your hypothesis or rejection of the hypothesis. I was working in one organization. The partner came to me and said, look, I need all those people out from this data set who will purchase the credit card by tomorrow. Okay? Your time starts now. Tomorrow, I cannot tell him that, no, sir, nobody out of this group is going to purchase the credit card. This is not the acceptable result. Which is the acceptable result? I tested his hypothesis and found that nobody is going to purchase your credit card, but that is not the outcome he wants. He said that no matter what, the result which I wanted should come from this analysis. Go to hell. Don't test the hypothesis. We want to collaborate with the government. We want the leaders like you to create the hypothesis. You have got your big department. You have got big data set. You have thought that, okay, I want to set up a thalassemia center. I want to set up a nephrology center into some part of the smaller place. You need to test. You have limited resource. So you need to know that you need to decide the pin code, priority of the pin code. In this order, I need to invest. In this order, I will invest, only then the result will be maximum. Because at the end of the day, we are working in a optimized, we are not working in a overwhelming scenario. We are working in the optimized scenario. We want to work with the department, and it is not the precondition. We can collaborate with the state, we can collaborate with the country, where there is a longer vision. Rome was not built in a day. The data comes later. First of all, you should, we want to work with a leader like you who has thought, okay, I want to solve this problem. The second question will be, where is the data? Whether the data is sufficient, for which that professor died. Now we have got the answer. So I'll tell you that, okay, this is your data. Now, I see a lot of people saying that, oh, we don't have data. Let's first collect the data. I think never it happened. Never it will happen in the future that you will have sufficient data. You will have to know that out of the data which is available right now, how I can start the first building block. So we are absolutely open to work with the leader like you, who has huge inclination towards the data, and all of us claim that we have huge amount of data. So let's collaborate to create the narration of the problem, then create the hypothesis, and then there are n number of mathematical methods through which we can ensure that even the limited data can produce actionable results. We can customize the solution for you guys. Thank you, ma'am.
Thank you. I think just to ensure that we utilize the time, I would break for questions from the audience so that we will have our panelists respond. And if there is time, then we'll go for the second round. Otherwise, we should, get a more engaging audience. Yes, please. And since lot of young students, you should ask questions. It's not, then only we'll realize that, okay, we have been making some sense. Otherwise, it's just becoming a monologue of people here. I'm sure if anything is, you need to clarify, please ask.
A small request, whoever has questions, please introduce yourself, and I request you to keep the question crisp and not a statement, please.
Sure. Very good afternoon to the esteemed panel. I'm Dr. Farhana. And my question is, like Sir rightly said, there's this predictive analysis that helped in COVID-19. My question is, out of the descriptive, predictive and prescriptive type of analysis, which is most relevant to the healthcare domain and why? If you could please give your expert opinion on this. Thank you.
Who wants to pick Subodh? Yeah.
So again, I would say, first of all, it is not that in a war between two persons, you choose a tank to fight with. I mean, what is the objective? And that is where I told you the null hypothesis. All these three, in most of 90% of the situation, a simple mean median mode, which is the moment statistics, can take care of your problem. The tragedy is that straight away we jump to the equation. I will create one fine regression model. No. All those statistics are absolutely important. You need to know which tool is to be applied. You test the tool against the null hypothesis and figure out the data for it. So all those things are absolutely important. You cannot put them in order.
Good afternoon to the panel. I am Sai Shri Kanda. I'm a student at IIM Rohtak. And my question was about how I wanted to know what were the biggest challenges that are there when we're trying to get telemedicine into the rural part of India. Because when Dr. Khan talked about Jammu and Kashmir and how they're able to, digitalize the entire thing, in a lot of rural India, there's no electricity also. And most of our states, the other states are like that. So what advice would you have for the other states that how can they go ahead with this, or what are the challenges? That's what I wanted to know.
So it's a great question. I'll talk a little bit more about science and talk a little less about the implementation challenges, because around the world, even in high-income countries, there are challenges in terms of bandwidth availability and all. Essentially, what telemedicine, I think telemedicine has been there even before COVID. Its importance has grown during the COVID times. But essentially what I want to highlight here is the business idea of telemedicine. Today in public healthcare in India, we've not really truly actualized the potential of telemedicine as a business idea. And when that grows, which basically means today the thinking, there's a need for a paradigm shift in the way we think about telemedicine. We think about telemedicine as only technology for people in rural areas, in areas where physicians are not available. I'm trying to propose that telemedicine is not only for them. Telemedicine is also for people who live in urban areas, people who live in metro cities. Because primarily if you have to travel from your place to a physician, take time, and there's a lot of time that you spend even in a big city. So essentially when technology is made available, it's not, and especially telemedicine, because that's a major shift that is happening in the US, and it will come to India as well. So what I'm trying to say is telemedicine is not just for people who live in far off areas. It's not meant only for people in rural areas. So even in a city like Hyderabad, instead of going to the physician in person, if the technology is so good, if the usability of the technology is so good, what would happen is you would probably sit at your home, wear your pajamas, sit before a physician and say, hey, this is what I can do. This is what is my problem. You'll be able to give your chief complaints. And if you have enough adequate variables, you'll be able to give a large amount of your physical data to the physician. And then now with increasing technology, all the data points that you need over a period of time can be made accessible. So telemedicine is not just about increasing access between the provider and the patient, but it's also giving those data points that the physician needs to get from the patient. So it doesn't need that the patient has to transport himself. Now, this looks like a slightly, like a Alice in Wonderland right now. But in the US, for instance, a lot of hospitals are moving away from brick and mortar and moving more towards these virtual hospitals. Now so it is not just telemedicine alone, it is these virtual hospitals that will come in the times to come. I mean, we've not grown till there, technology and because when you build technology, you want to look at it as a socio-technical system. It's not just about creating technology, there are social realities, there are realities around human beings. And that is the reason why when technology gets adopted in healthcare, it gets adopted far more slower than various other sectors, precisely because of these reasons. So I think in telemedicine, what I would say is what we are seeing is just a small tip of the iceberg. There's much more in terms of the potential of telemedicine, both in India as well as outside. Hope that's helpful.
Just add up to what Dr. Karthik said. Her more concern is that you see wherever there is hilly terrain, there is hard to reach, inaccessible areas where there is no electricity sometimes, maybe there is no mobility, even internet connectivity. How do you do the telemedicine for those areas? You see, these challenges are for northern and northeast states and UTs. We have a huge challenge in that. Of course, we are trying to bridge that challenge, in two ways. We are creating small mobile units which will go to all the far-flung areas. Number one, internet proliferation and connectivity is going all through J&K, and the proliferation is almost reaching 90% now. Number one. Number two, electricity under the rural electrification program. We are trying to bring electricity to all the villages, all the remotest areas of J&K. That is the Prime Minister's vision for J&K. And number three, when you talk about small innovations, what you have done is, for example, if a person does not have a smartphone in an area of, say, Kupwara, Matsil area, or some area which is Doda, Kishtwar, Badarwa. So what we do is we make a Abha card, say digital, I'm saying, from the digital part of it. So the Abha card will, he doesn't need a smart card. The Abha card will carry a QR code for him. So the reverse scan and pull will happen. He will go to a health facility, show his Abha card. The person will, from a gun scan his demographics and capture it, and then he will be logged into the system. And having said that, we also want to integrate, suppose we have TB Mukt Bharat, we have Anemia Mukt Bharat, very important programs in India, which are challenging to us. There are teams, mobile teams, which go have health checkups in those areas from time to time. Capture information, gather their statistics, have their health checkup done, and then, sometimes relay it on, come down and relay it on internet, through devices. That is what we have done. But till a robust system of internet doesn't come into the most, which sometimes seems not achievable, because people in our J&K, you will be amazed that they are living on the top of a mountain. There are 3 houses. On another mountain, there are 3 houses. So that kind of approach would be only by having mobile teams which access them, do their vaccination, have health cards, Sabha cards prepared, and bring them into the ecosystem of digital health. That's my understanding.
When we do clinical trials, in one arm, if there is placebo, and in other arm, the drug of investigation is there, can we accept those trials in India? Because if we have a standard of drug, like say for example, one disease is there, we have been treating with one particular drug, the new drug should be better than that particular drug. That particular trials only, if it can be accepted in India, that would be safeguarding the ethical interest of our country. For example, in China, they will not allow any drug in which the Chinese population are not included in that drug trial. They will not allow the drug to be sold in their country. That mandate, they keep it, and their drug controller of that particular China will not allow that drug to be sold in the country. If we can have that type of restrictions, only probably we will have a better safeguard of our patients, I think. What do you say? Is it acceptable to allow placebo as one of the arms? Because it is continuing like that in spite of having so many advances in trials. Because I have conducted American Society of Clinical Oncology trial in India, this particular topic, because for that same reason the media is highlighting these trials have been used as a guinea pigs for our Indian population, because most of the trials are sponsored by multinational companies. So for that reason, I'm asking this question.
He has got the question, so he'll respond.
So this is a very sensitive topic. Let me answer it in three parts, and I'm not an authority in this, nor am I going to speak for the Pharmaceutical Authority of India. We have a regulator who regulates all the drugs that come to India. So I'm going to talk more from a scientist point of view, not from a bureaucratic point of view. So one, what happens is most MNCs, why do they come to India? So MNCs come to India because conducting clinical trials is much easier in India. Two, when drugs come, drugs are tested in two broad parts. First is safety. So first is, even before you bring it to human beings, you test them first on animals, and then you do two parts in human beings. One is safety testing, and second is efficacious testing, which means the therapeutic efficacy of the drug, very broadly. So first is, once the drug is safe on human beings, the second part is it efficacious? Is it giving the therapeutic efficacy that the drug is initially prepared for? Now, the part that you said, what you're trying to say is a randomized control trial, which means you have a placebo and then you have the intervention. Now, typically, a clinical trial is just a general word, but actually what happens in a clinical trial is, most often than not, it will be a randomized control trial. But it doesn't mean that all clinical trials have to be a randomized control trial. In MNCs prefer India primarily because of the population that we have. Now, the other part is, should we allow MNCs to do clinical trials in India? Okay, that's a big ethical question. Two, in China, you said, but the reality is, even in China, the biggest problem is for drugs that treat rare diseases. For common diseases, there's no problem. I mean, India doesn't need to depend on drugs from other countries for common diseases. It's only for rare diseases that there is a difference between the Chinese regulation and the Indian regulation. When you get a rare disease, the family wants quick treatment. Okay? People from India go and join clinical trials in the US so that you get that rare drug. Okay, and they join clinical trials in the US as well. I'm talking of those people who can afford. Now, some of these rare drugs, when they come to India and they do a clinical trial, families are desperate to get treated. And that's the reason why they join on those clinical trials. And that I'm talking from a physician standpoint. In China, because the regulations are very higher, very often what happens is, some of these rare diseases, that's their country's norm, that they don't want to allow any of these rare diseases to be treated in their population. But some of these rare drugs, what I want to say is, they may not be efficacious, but they will definitely be safe. It's only when they're safe, they come to the next stage of the testing process. So some of what you read in media is not always very true. But yes, there can be black sheep. I'm not ruling that out at all. But I'm talking in general, very broad strokes. When you see clinical trials for efficacy, they're safe. They may not reach the efficacy part, but they will definitely be safe for human beings. It's not that we are being treated as guinea pigs.
Thank you, sir. I think Dr. Ratan, sir, online has a comment.
So I would just want to re-emphasize what I said at the beginning. I think the monitoring and evaluation is a very critical aspect. And for that, I think data is the most important input. And what we've seen is the analysis of data is not taken seriously, due to which we miss a lot of changes which can be brought about in the way in which we function. So my emphasis would be on creation of a monitoring and evaluation cell at all departments, which can continuously look at the data coming from the field and take corrections, which will give us all good result. Kerala has done that very successfully, and we are also looking at reinforcing this in all other departments. So in the health department, we have been able to create a M&E division under NHM, and NHM has been supported quite efficiently by all the relevant stakeholders. So my emphasis would be on monitoring and evaluation, which is likely to give us good results in the future.
Thank you, sir. Mr. Prashant.
Just 3 crisp points. There will not be any data birthday. You should start applying data analytics in whatever form and shape the data is. That is one. Secondly, data analytics needs two investment. One is monetary and second is cultural investment. So you have to, as a leader, you will have to instill this culture of usage of data analytics. That is second. Then the effort. I mean, instilling a culture of data analytics in the system takes effort. I sincerely and earnestly request all of you, because you are the leader, to instill this feature in the system. The analytics brings revolution through the impact. Analytics is not revolution. So the day analytics will bring change, it will bring revolution. Thank you.
So I just want to connect with one of the questions which came when I had the opportunity after academics to work in the government, and I had actually done my PhD on a lot of econometric analysis. The first thing the principal secretary told me was, whatever you do, everybody should understand, and if a simple percentage is actually good enough. So analytics is all about how everybody can understand and make the best use. Thank you.
As my executive director said earlier, our most priority will be the monitoring and evaluation. We are all sitting on a huge data, and if we are not utilizing it in proper way, they won't help us in future planning and all. So we are giving most priority to the monitoring and evaluation, and we'll continue with that. Thank you.
From the government perspective, yes, government really wants data analytics to make inroads, as you have been saying, from prescriptive, predictive, and descriptive point of view. And COVID has really raised the importance, how data analysis has been utilized in planning, forecasting, and demand planning. And I'll just give a small example, like for example, why data analysis is very important. There was a study in USA where they said because of the overdose of drugs, there had identified around 742 risk factors, and in fact, because of the overdose, it has also led to problem of road safety. So that itself shows that how important it is as regards data analysis is concerned. Thank you so very much for your patient hearing.
I will quickly sum it up by saying that the digital, interventions, whichever we are introducing in our systems. I'll give you a small example of J&K. J&K used to be a princely state once upon a time, and there was this darbar move practice of shifting office winters to Jammu and summers to Srinagar. And imagine the cost of this practice in the government till recently was around 400 crores. Just the shifting of offices, the complete offices in Jammu along with files, computers would be loaded into trucks and sent to Srinagar. Srinagar Secretariat would get a facelift every year, and Jammu Secretariat would get a facelift in some winters when in November it used to come. So we launched e-office. 400 different departments, small, big, are now running on e-office platform. And this e-office platform has created such ease of business within the government. You cannot even imagine right now that everything, I'm sitting here, I have my e-office, I can access it, and if there is a file, I'll send it back or up or down, wherever. So this entire digital revolution has created ease of business, ease of life. And the ultimate aim is to increase the happiness index of this country. People should start becoming happy with ease of, and I wish this digital, intervention brings more and more happiness to our country. Thank you.
My comment is actually data is everywhere. Data will emerge every time. So only thing we have to look at the data, analyze the data, and plan it for the betterment of the people. Like in NHM and Arogyasri in our state, we effectively utilize the data to create the infrastructure at the district level. Like in some districts are having more burden of kidney disease, heart disease. In wherever the heart disease, there cath labs are being established. Where cancer burden is high, we made a chloropath maps also in the state. Where disease burden is there, we can plan this data for the benefit of the people. The data is everywhere. If at all you don't use it, it will be anywhere, it will be generated. Only we have to utilize the data to create the infrastructure, create the manpower to address the societal problems. That's the thing that I want to tell. Thanks.
Thanks a lot to all the panelists for ensuring that this is an interesting session and we are more responsive to the audience. I can see everyone is charged up. now for lunch. So thank you very much.
Thank you, ma'am. It was a wonderful session, how analytics and digital intervention is bettering and changing the face of healthcare in India today. And we had a really interactive session as well. Thanks to all the panelists. I would like to call forward Dr. Karthik Adappa, IAS Special Secretary, Public Health and Family Welfare Department, Punjab, to give away the mementos as token of appreciation to our panelists here. Please come forward, sir. I would like to call forward Dr. Bijoy E., Joint Director Operations, State Health Agency, to please come forward to receive the memento. On behalf of Dr. Ratan Kelkar, IAS Secretary, Medical Education and Executive, Director, State Health Authority, Government of Kerala. Further, I would like to call upon Professor Dr. Gangadhar Taduri, MD, DM, OSD to CM Health, Technical Advisor, Department of Health, Medical and Family Welfare, Government of Telangana. I would like to call upon Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir. I would like to further call upon Ms. Indrani Laskar, Joint Secretary, Health and Family Welfare, Department, Government of Telangana, Government of Assam. Further, I would like to call upon Dr. Subodh, Professor and Director, Center for Healthcare Management, Director, ASCI, PGDM, Hospital Management, Hyderabad. I would further like to call upon our moderator for this panel discussion, Dr. Sudha Chandrasekhar, Public Health Specialist and Health Economist, Advisor, Health System Transformation Platforms. Finally, the SAS specialist, I would like to call upon Shri Prashant Rai, Senior Business Solution Manager, SAS India. I would like to call upon Radha Krishna B., Director Customer Advisory, SAS India, onto the dais, please. Sir would like to hand over the SAS baggages to our panelists here. I would like to call Sudhir Gautam onto the stage, please. CEO and Editor-in-Chief, IndiGlobal Media Network, to give away a big token of appreciation to Dr. Karthik Adappa, IAS Special Secretary, Public Health and Family Welfare Department, Punjab.
Thank you very much, Prerna. Dr. Radhakrishna would like to give a gift hamper to all our esteemed speakers who have joined us from across the country. To Dr. Gangadhar, representing the Telangana State Government. To Dr. Karthik Adappa. Now I would request all the esteemed speakers to come forward for a group picture over here.
I would like Dr. Karthik to please come ahead